They can.
Everybody's there?
Yes, they can hear you, but they can't respond.
Okay. Oh, that's fantastic. Yeah, good afternoon, friends. It's my privilege to address you on this day when we are relaunching our letrozole. Letrozole 2.5 milligram. Let me tell you, my dear friends, the market. Market is 35 crores and market has been, there for last 1 year only after the lifting of the ban. And the growth is more than 100%. Now you have to choose and take how much you want. But to be very honest with you, seeing your new product's performance, that does not give me much confidence. Because whatever we have launched in last 12 months, products have not done well. BPOS is our one current example, where we started, I think 50 lakhs, 55 lakhs, then again rolling back to 40, 45 lakhs. Saying all these things, but still I feel that the kind of passion the team has, you all have that. You are enthusiastic, you need to focus little better, and to be very honest with you guys, work input, wherever I meet you, whatever the platform is, I reiterate my only one thing, focus is only on one thing, increase your work input and see that all selected doctor for selected products, please address them thoroughly well. Like letrozole, now is the product you must have selected by now. The products, go and launch now. All the very best. I'm there for, I think, next 15-20 minutes, whatever the question comes. The team is here to answer all that. Mr. Rakesh is there, doctor is there, your Ashish is there. Everyone is here. All the very best and create a history now. I still distinctly remember, to be very honest, this is a very close to my heart, this product. When I was in pharma, I launched this product and product was going very well. And it is so similar, we had to now add A. Still it gives, once you go and tell doctor, letrozole, doctor understands he's talking or she is talking about letrozole. Let us create history. All the very best. Hip hip, hooray. Hip hip, hooray. Hip hip, hooray.
Thank you, sir.
Yeah. You are coming here?
This, I think this camera can move. Yeah, thank you. Good afternoon to all my friends. My name is Ashish Kumar Singh, DGM Marketing with Phoenix Division. So with me, as you have already heard Rakesh sir's voice, and apart from me, there is Mr. Rakesh Singhal, who is our training manager, and then there is also Dr. Abhay Mane, who is from the medical department, and Saurabh Joshi is also there, who is the brand manager, who would be handling our letrozole. So friends, as the closing is over and letrozole must have been built in each and every headquarter. Now, that's why we kept the launch, this unique kind of a webinar launch at this point of time, so that as soon as the product reaches in your specific headquarter, you all would be ready to launch it and then launch it with a bang. So I do not want to steal thunder from the presentations of Mr. Rakesh Singhal and Saurabh, but just to tell you something quickly, as Rakesh sir has specifically mentioned, that this is a kind of a relaunch of our brand letrozole, right? So which is what we are going to relaunch. As you all now, you must be thinking that why relaunch and why exactly we stopped promoting this particular product. So I'm sure that your leaders are there with you and they must have communicated to you a little history about the brand. Like, this brand was majorly promoted in ovulation induction, but there were certain safety concerns on the molecule, because of which this molecule got banned in these indications, right? And that's why there were good number of brands who stopped promoting letrozole molecule or their brands of letrozole molecule to gynecologists. Of late, DCGI has given approval for this molecule, and the ban on the promotion of this molecule is lifted. So that's why you would find the majority, good number of companies who are aggressively promoting or who are aggressive in gynecology, you would experience brands of letrozole from all these companies at the marketplace. And we are also one of them. Now, since we have a brand equity at the marketplace, because in 2011 we stopped our promotion, so the doctor is still remembered there used to be a brand of letrozole or with the brand name Lutrozole. So that's why we decided to again relaunch with the same brand name at the marketplace. So this is going to be a kind of a aggressive launch, and then definitely one of the core strategy, as I said that definitely Mr. Saurabh would be covering in his presentation. One of the important strategy would be to go back to those doctors who were at that point of time prescribing our Lutrozole. Now, many of you are relatively new in Phoenix and you did not experience the launch of Lutrozole. I would suggest you remain in touch with your leaders in the region, and then they would help you that which were the doctors who were earlier prescribing our Lutrozole brand. So with this, now I would be handing over the session to Mr. Rakesh Singhal, who would take you all through these medical queries and specifically the medical aspects related to our brand Lutrozole. So as in fact I am experiencing some of the questions already started coming to us. You all have already been communicated that when you are watching this webinar, there is a section over there at the bottom where you can exactly put if you have any medical query or even marketing query as well going forward during the marketing presentation. So you keep on sending your medical or marketing query through that section. It would be reaching out to us. We would be filtering all the relevant queries and then would be addressing it during the presentation, or maybe after the presentation we would be giving some significant time to discuss all these queries, right? So now handing over the session to Mr. Rakesh Singhal. Thank you.
Thank you, Ashish. Are we projecting both the screen and my video? Yes. Both? Okay. Good afternoon, friends. I think the stage has been set by Rakesh sir and Ashish. So this molecule is something which is coming back with a bang, and it is in the space of infertility. And let me tell you one thing, that this brand, the molecule letrozole, has a great potential in the market. So we would have a look at letrozole. As you can see on your screens, letrozole in ovulation induction. Before we start discussing the topic, it would be very useful if you could have a pen and a notebook by your side, so that whatever important points you feel you can jot down. And at the same time, if any queries come to your mind, you can key in your queries on the panel in your screen where the question has been given. So let's start discussing the topic. I'll put on the first slide. I hope you can see the slide. If the slide is not clear, you can let us know. Or if the slide is not appearing, please do let us know. So this is the roadmap for discussion. We'll first have a look at the session objectives. Then we will begin by the anatomy and the physiology of the female reproductive system. So where we first understand how does the female reproductive system actually work, what are the hormones which play a role, what is the 28-day menstrual cycle, and how it is controlled by the different hormones. Then we will come down to the disorders, that is infertility. What exactly is infertility? What causes infertility? And how does a infertility doctor look at the management of infertility? And then, as you can see on your screens, after infertility, we go to ovulation, ovulatory disorders and the management. So you would get to understand, this would be our major discussion area for understanding how a doctor would prescribe letrozole. and what is the place in the clinical practice of the doctor. And after that, we would actually come to letrozole, where we will have a look at all the details of letrozole. So at the end of this session, you should be able to talk about the structure and function of the female reproductive system. You should be able to define the role of hormones in maintaining a healthy menstrual cycle. Then what is infertility, its major causes, major approach towards infertility management, why and how a doctor should switch to letrozole, and of course, you would be able to understand which clinical trials are available and how letrozole is better than other ovulation induction drugs which are present in the market. So let us come to the first part, the female reproductive system. You can see a picture of the female reproductive system on your screen. So the entire female reproductive system you can see is present in the pelvic area of the female body, and starting from inside coming to the outside, there is a pair of ovaries. So the ovaries are known as the primary gonads because they produce the gametes, which is the ovum in the case of a female. Then there is a pair of fallopian tubes. Each fallopian tube, in the picture you may feel that the fallopian tube is connecting with the ovary, but the fallopian tube does not exactly touch the ovary, but it does play a very important role in collecting the ovum whenever ovulation happens. So ovary, the fallopian tube, which basically is a transit pathway for the ovum, and then you have the main organ, which is the uterus. The uterus nourishes the ovum till the time of childbirth. And then you have the cervix. Cervix is basically a narrow opening of the uterus and connects the uterus with the vaginal canal. So for today's discussion, our main focus would be on the ovary, the function of the ovary. As we just discussed, the main function of the ovary is to produce an ovum. Now, at this point of time, let me mention about a couple of points. For a healthy pregnancy, a good quality ovum is required, and a good quality of endometrial lining that can hold the ovum and provide the sufficient nutrition and nourishment to the ovum for the developing embryo is required. At the same time, we also do understand that in normal human physiology, in one cycle, only one ovum is released. And that is the reason why in humans, in a single pregnancy, you will see that maximum of the times only one pregnancy happens. It does not result into multiple pregnancies. And single pregnancy is something which is most desired in humans. Please keep this in mind, because when we proceed with our discussions and we reach our product that we are targeting today, letrozole, you would be able to understand how letrozole takes us towards more desired pregnancy outcomes as compared to the other molecules which are available in this sphere today. Our next point of discussion, let us see what is the human menstrual cycle and what roles the hormones play in the human menstrual cycle. Typically, this is very important. Typically, a human menstrual cycle is for 28 days. So we are talking, remember here, friends, we are talking of the normal, healthy physiological process of the body. So a normal adult female will have a menstrual cycle for 28 days. And this menstrual cycle will be divided into the 4 parts that you can see, the 4 phases of the menstrual cycle that you can see on your screen. The first is menstruation. Menstruation is basically where the old endometrial lining sheds and it comes out in the form of menstruation through the vaginal canal. And in our common day-to-day language, we call it the period which a woman has. And this lasts for roughly about 3 to 5 days, depending upon individual to individual. Then the next is the follicular phase. The follicular phase, as you can see, starts immediately after the menstruation. And follicular, the word itself denotes a follicle. So please remember, this is the phase where once the menstrual period of a woman has stopped, the follicle in the ovary starts growing. I'm going to show you a picture also, which will make these things clear to you. So the follicle starts growing. It's basically a primordial follicle which grows into a primary follicle. The primary follicle grows into a secondary follicle, and then a mature graphene follicle. This phase is particularly known as the follicular phase, the growth period, and this is most important. We are going to focus on this very, very sharply to discuss our product letrozole. And once the mature graphene follicle has formed, it means it's a sac-like structure which is filled by fluid, and inside the sac-like structure there is a healthy ovum which is now ready to be released. So this healthy ovum causes a swelling on the surface of the ovary. We'll see a picture where you will be able to understand this more clearly. And under the influence of certain hormones, which we will discuss, the ovulation happens, which means the rupture of the graphene follicle happens, and it releases the ovum, which is then picked up by the fallopian tube and carried towards the uterus. Last is the luteal phase. The luteal phase denotes that once the ovulation has happened, the graphene follicle is now empty. It gets converted into a gland which is known as corpus luteum, and this corpus luteum starts secreting progesterone. So from that corpus luteum came the name, the luteal phase. So let's remember this. The first is the bleeding period. The second is the growth of the follicle. The third is the release of the ovum from a healthy follicle. And the fourth is the remaining follicle starts secreting progesterone and estrogen. So this basically constitutes the 28 days. And remember that day one of the menstrual cycle is actually when the menses of a woman begins. It is not at the end of the menses, it is the beginning of the menses. So let us basically have a look at how the hormones, they rise and fall and what role they play during this menstrual cycle. So that takes us to the next slide. Now, there is something which is a very interesting phenomenon which is known as the hypothalamic pituitary ovarian axis. From where does this name come? This name comes from an organ, hypothalamus, which is present at the base of the human brain. It is sort of a circuit. You can also compare it with a telephone junction box, where a lot of functions are performed and a lot of coordination between different functions of the body happens. Then at the base of the hypothalamus, there is a small gland which is known as the pituitary gland. The anterior part of the pituitary gland is actually linked with the human reproductive system. And then there is the ovary, which we have seen in the human female reproductive system. So basically, how does the interaction between hypothalamus, pituitary, and ovary happen? That is known as the HPO axis. At the beginning of the cycle, the hypothalamus is activated. The hypothalamus releases a hormone which is known as the gonadotropin releasing hormone, which you can see is denoted by this plus sign. Plus means increase and minus would mean decrease. So this activates this hormone which is released by the hypothalamus. It activates the pituitary gland. The pituitary gland in response starts secreting another hormone which is known as follicle stimulating hormone, denoted by the abbreviation FSH. And under the influence of this FSH, inside the ovary, the follicles, they start growing, and the ovum, basically the oocyte which is present inside the follicle, it starts maturing and moves towards a mature graphene follicle. Towards the end of the follicle phase, when the ovum is mature, you can see there is another hormone which is luteinizing hormone, denoted by the letters LH. The luteinizing hormone is released, which basically leads to the release of the ovum, which we know as ovulation. Now, very interesting, while the FSH is being secreted and the follicle is growing inside the ovary, what happens is there is another hormone which is released by the name of estrogen. This estrogen, we need to understand. If you remember in the beginning of the discussion, I had mentioned that in a normal human physiology, in a cycle only one ovum is released, which results in only one pregnancy. Why does this happen? Because estrogen which is released from where does this estrogen come? The estrogen comes from the growing follicles. The estrogen causes a negative feedback. You can see this negative sign, negative feedback to the hypothalamus and the pituitary. So you can see the two negative signs. You can understand that if the hypothalamus is suppressed and the pituitary is suppressed, it will result in the reduced production of follicle stimulating hormone. So when follicle stimulating hormone reduces, the growth of the follicles inside the ovary is arrested, other than one dominant follicle which keeps on growing, and that becomes the mature graphene follicle and releases the ovum. So what we need to keep in mind here is that in a human physiology, normal human physiology, there is mono-ovulation. Mono means one, ovulation means release of ovum. So therefore there is one ovum release, there is one pregnancy in one cycle in humans, which is of course the desired thing. Now, all these changes that I have talked about, let us do a quick recap in 2-3 different ways. Look at this picture. This picture, friends, is the picture of an ovary. So what you can see here, I'll just guide you through this picture. This is the lining of the ovary. You can see the red and the blue denotes the blood supply inside the ovary through the nerves and through the veins and the arteries. And then these are the follicles, which basically this is a diagrammatic representation of what happens to the follicles. So from here, if you can look at my pointer, from here, this entire thing represents 28 days of the menstrual cycle. Now, let's begin from here. I'll show you what is happening and we'll correlate it with the hormone, which is responsible for these changes inside the ovary. If you remember, in the beginning, we said that in the beginning of the cycle, the hypothalamus fires and it produces GnRH, that is a gonadotropin releasing hormone. It activates the pituitary gland. The pituitary gland secretes FSH. Now this FSH, if you remember, results in the growth of the primary follicle, the primordial follicle to the primary follicle. So you can see here, the story begins with multiple. There are multiple primordial follicles. The story begins with multiple primordial follicles. All these primordial follicles you can see. Now this is under the influence of FSH that this growth happens. But ultimately you will see that not all primordial follicles, they keep on growing. If you can see here, these follicles are not growing, but this follicle is growing. It is because somewhere between this stage and this stage, estrogen has started coming from these follicles. As a result of this, if you remember, negative feedback is there and the quantity of FSH is reducing. So the amount of FSH which comes is sufficient only for the primary follicle to become secondary follicle and then into the mature. You can see here, graphene follicle, only one ovum, oocyte inside, and it is producing a bulge on the surface of the ovary. Now here is, if you remember, that I told you that luteinizing hormone LH comes. Now this is the stage where LH comes, and LH leads to the release of the ovum from the graphene follicle, and this process is known as ovulation. This ovum gets picked up by the fallopian tube and is carried towards the uterus. You can see once the graphene follicle has released its ovum, left behind is a plain follicle, and see, this plain follicle is getting converted into a gland. This is a developing corpus luteum, and this is a fully developed corpus luteum, and this is a gland which secretes progesterone and estrogen, which are very, very important. Remember, progesterone and estrogen, if a lady becomes pregnant, both progesterone and estrogen are available till the end of the pregnancy, till the childbirth. So therefore, the corpus luteum becomes very important. Now, if we look at the turn of the events, I would urge that you remember a couple of days. Now, between this phase, this is at the start, so it is basically at day 0. So this and this, between the primordial and primary follicle, is basically somewhere till about day 3 to day 5. Here, the estrogen starts coming. Somewhere around day 3, the estrogen starts coming. The quantity keeps on increasing. So between primary follicle, secondary follicle, and this is about day 3 or 4 till about day 14, 13. So day 14, the ovulation happens, and then it takes about 2 to 3 days to become the corpus luteum. So the corpus luteum is fully formed somewhere around day 17, when the quantity of progesterone and estrogen is at the peak, starts peaking. Now, if pregnancy happens, the corpus luteum is maintained. If the pregnancy does not happen, the corpus luteum degenerates by about 23rd, 24th day, and around 28th day, the next cycle starts. So why am I insisting that you remember this? Because, in the evaluation of infertility, when we go ahead in our discussion, you will see somewhere mid-cycle progesterone estimation, this comes. Now, mid-cycle means what? Mid-cycle means this around 22 days. So you can understand that if progesterone is good at 22 days, it means corpus luteum is healthy, which means ovulation has happened. You can understand that corpus luteum will form only if ovulation has happened. If ovulation has not happened, corpus luteum will not form, it will not produce progesterone. So day 22 of the cycle, if you do a blood test which gives you the progesterone level, and if you see that the progesterone level is high, you are very confident that ovulation has happened. If progesterone levels are low, you know corpus luteum has not formed, and if corpus luteum has not formed, it is a clear indication that ovulation has not happened. So therefore, remember, this point is going to be very important in the evaluation. So when we go to our product letrozole, this will give you a very clear idea where and how letrozole is to be used. So let us carry our discussion ahead. So we can see here that hormones, these are the 4 hormones that we have discussed. By now, I am sure you have captured the roles of these hormones in your mind. FSH stands for follicle stimulating hormone. I gave a slight pause. I thought you will think in your mind. So FSH stands for follicle stimulating hormone, stimulates the growth of follicles in the ovary. Can you capture the picture? We just saw before this picture. What is LH? Luteinizing hormone, causes ovulation and also maintains the corpus luteum. Estrogen, when does estrogen come? Somewhere here. Okay, what is the role of estrogen? Number 1, it stimulates the growth of the endometrium. So it prepares the endometrium for the arrival of the fertilized ovum. And second, it also gives a negative feedback to the hypothalamus and the pituitary. So therefore, if you remember, we said that because of this negative feedback, FSH reduces, only one ovum grows, and it results only in mono-ovulation, therefore single pregnancy in the humans. Then progesterone. Where does progesterone come? After the formation of the corpus luteum. So progesterone, it maintains the endometrial growth and nourishment, so it keeps the endometrium inside the uterus. Endometrium is the inner lining of the uterus, which holds the fertilized ovum and nourishes it for growth, and it also closes the cervix post-ovulation. So this is how you can see the 4 hormones, they play a role. Now let me try to quickly tell you what is this picture about. This picture is divided into 2 parts. Where I have placed my pointer, one is above this. So this is what happens in the ovary, and one is below this. This is what happens in the uterus. Inside the ovary, if you remember, there is a primordial follicle, grows into primary, secondary, mature follicle, releases the ovum, and this gets converted into the corpus luteum. Inside the uterus, if you remember, the first 3 to 5 days, this red shows the menses, that is the uterus, the endometrial lining of the uterus being shed in the form of periods or menstrual periods. So therefore you can see the thickness, this thickness of the endometrium is reducing till about 5 days. After that, the endometrial lining starts growing. The endometrial lining is maximum towards the mid-cycle, 20-22 days. And if pregnancy does not happen, this will start breaking and the new cycle will again begin from here. But if a pregnancy happens, this endometrial thickness will be maintained like this. will be maintained like this under the influence of estrogen and progesterone. So you can see here, beginning of the cycle, let's divide into beginning of the cycle, middle of the cycle. So basically, let's divide it into menstrual period, follicular phase, ovulation, which happens on day 14, and the luteal phase. So what is the level? You can see here. This line denotes the luteinizing hormone. This line denotes the FSH. Then you have the estrogen and you have the progesterone. So you can see here that this is where the primary follicle is growing into secondary follicle, and you can see the level of estrogen starts rising. Friends, this stage is very, very important because on one side the estrogen is increasing and you can see on the other side the FSH is reducing. And this is the reason why there is one pregnancy in humans. We'll get into the more details when we discuss. So you can see here, day 17, you will see the progesterone level starts rising, which matches with the formation of the corpus luteum. And maximum, so we talked about mid-cycle progesterone estimation. So this is the mid-cycle progesterone estimation, around 22. If the progesterone level is high, it means ovulation has happened. If progesterone level is low, it means ovulation has not happened. So at this point of time, I hope the normal anatomy physiology of the human reproductive system, the 28-day menstrual cycle, how it is divided into the different phases, and what is the role of the 4 hormones is quite clear to you. So give me a minute, I'll connect a video. I'll show you a video which will summarize the entire thing once again.
Female reproductive cycles are initiated at puberty, usually between the ages of 10 and 14. Each reproductive cycle, which averages 28 days, consists of a sequence of changes that occur in the ovaries and uterus. During each reproductive cycle, gonadotropin-releasing hormone, or GnRH, from the hypothalamus stimulates the anterior pituitary to release 2 gonadotropic hormones, follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH. The target organ for these 2 hormones is the ovary. The female reproductive cycle has 2 components, the ovarian cycle and the uterine cycle. Ovulation occurs on day 14 of the 28-day ovarian cycle. The 14 days prior to ovulation are known as the follicular phase, while the 14 days following.
आता मैं परत प्ले करते हैं. केले.
अभी प्ले कीजिए स्टार्ट.
Okay.
Just tell them that you are starting from the beginning.
Okay, I think the screen was not shared with you, friends, so we'll replay the video once again. If you're not able to see the video, please do put your query, not able to see the video, and we'll be able to understand.
Female reproductive cycles are initiated at puberty, usually between the ages of 10 and 14. Each reproductive cycle, which averages 28 days, consists of a sequence of changes that occur in the ovaries and uterus. During each reproductive cycle, gonadotropin-releasing hormone, or GnRH, from the hypothalamus stimulates the anterior pituitary to release 2 gonadotropic hormones, follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH. The target organ for these 2 hormones is the ovary. Each female reproductive cycle has 2 components, the ovarian cycle and the uterine cycle. Ovulation occurs on day 14 of the 28-day ovarian cycle. The 14 days prior to ovulation are known as the follicular phase, while the 14 days following ovulation constitute the luteal phase. The ovarian cycle is regulated by changing levels of FSH and LH. Ovulation occurs on day 14 of the 28-day uterine cycle. The 14 days prior to ovulation are subdivided into a menstrual phase, days 1 to 5, and a proliferative phase, days 6 to 14. The 14 days after ovulation constitute the secretory phase. The uterine cycle is controlled by the ovarian hormones, estrogen and progesterone. The events in the ovary prior to ovulation constitute the follicular phase of the ovarian cycle. In the first 5 days, increased GnRH stimulates the anterior pituitary to increase production of FSH and LH. This stimulates primordial follicles in the ovary to mature into primary follicles, each containing a diploid primary oocyte that is arrested in prophase 1 of meiosis I. At the same time in the uterine cycle, decreasing levels of progesterone lead to sloughing or shedding of the endometrial lining. This is the menstrual phase, commonly referred to as a woman's period. In the ovary during the second part of the follicular phase, days 6 to 13, a small number of primary follicles form secondary follicles. About 2 days before ovulation, under the influence of increasing levels of LH and FSH, the follicle expands to form a swelling on the surface of the ovary. Approximately 16 hours before ovulation, the levels of FSH and LH surge to cause the final maturation of the follicle, now called a mature or Graafian follicle. Just prior to ovulation, the primary oocyte completes meiosis I to form a haploid secondary oocyte. Simultaneously, the lining of the endometrium begins to reform under the influence of estrogen produced by the ovarian follicular cells. This is known as the proliferative phase of the uterine cycle. As the level of LH peaks, proteolytic enzymes produced in the follicle cause its wall to weaken and rupture. Ovulation is the release of the secondary oocyte from the mature follicle. After ovulation, the ovary enters the luteal phase of the ovarian cycle, days 15 to 28. During this period, the remaining ovarian follicular cells form a corpus luteum, which produces the hormones progesterone and estrogen. Progesterone and estrogen from the corpus luteum stimulate further thickening of the endometrium in the secretory phase of the uterine cycle, days 15 to 28. If fertilization and implantation occur, cells at the implantation site in the uterus begin to produce human chorionic gonadotropin, or HCG. HCG prevents degeneration of the corpus luteum, so that elevated progesterone and estrogen levels are maintained to prevent shedding of the uterine lining at the end of the uterine cycle. After 8 to 12 weeks, the corpus luteum ceases to produce progesterone and estrogen and degenerates to become the corpus albicans. The placenta in the uterus replaces the corpus luteum in producing progesterone and estrogen. If fertilization does not occur, the corpus luteum becomes a corpus albicans by the end of the cycle. This leads to decreased levels of progesterone and estrogen and results in menstruation and the beginning of the next uterine cycle.
Friends, we are back to our discussion. I hope the anatomy and physiology of the human reproductive system would be clear by now. Repeating myself, points to be kept in the mind is that the role of the hormone is very, very important, and there is an increase and decrease in the level of various hormones, and it is this increase and decrease of the hormones which is very, very important. From the point of view of our discussion of this product, note this point, that increase in estrogen here relates to the decrease in follicle stimulating hormone. So in the presence of estrogen, the ovary will produce less of the pituitary gland will produce less of FSH, and therefore the growth of the follicle will be less. So this is a very important point which will come up during our discussion at a later stage again. So we have seen that video. Now we go to the next portion of our discussion, that is infertility. What exactly is infertility? The definition of infertility according to WHO, infertility is a disease of the reproductive system defined by the failure to achieve a clinical pregnancy after 12 months of more of regular unprotected sexual intercourse. So a couple who has been trying to conceive a baby for the last 12 months, but they have been unsuccessful, that is termed as infertility. What is the prevalence of infertility very less in India? No, friends. The prevalence of primary infertility is around 12.6% as per a study done in Mysore, India. There are several risk factors: higher age at marriage, urban lifestyles, obesity, smoking and alcohol consumption, sexually transmitted diseases, and sedentary lifestyle. If you will see from here, higher age of marriage is a current phenomenon. Urban lifestyle, yes, on the rise. Obesity, yes, on the rise. Smoking and alcohol consumption, yes, on the rise. Sedentary lifestyle, yes, on the rise. So you can see that most of the risk factors for infertility are on the rise with advancement and more people living and working in metro cities and even B category towns. So that is the reason why the incidence of infertility is quite high. 12.6% by any count is very high, and it is on the rise. So which actually opens up the market of infertility with a good growth rate. Now, something which is very important. What are the different causes of female infertility? You would look at this, that ovulatory disorders, endometriosis, pelvic adhesions, tubal blockage, other tubal abnormalities, hyperprolactinemia, and unexplained causes of infertility are among the different causes. But what I am sure has caught your eyes is this, the blue. Ovulatory disorders, 25% of the times, the reason for infertility is ovulatory disorders. And specifically, ovulatory disorders means what? Is the lack of ability of the ovary to produce a viable ovum for fertilization and causing pregnancy. So 25% of this, we call it as anovulatory infertility. Anovulation, an stands for no, ovulation stands for release of ovum. So 25% of the cause is failure to produce a healthy ovum for pregnancy. And this is one of the most common clinical presentations when an infertile couple goes to a infertility specialist, and therefore it becomes one of the major criteria for the management of infertility in an infertility doctor's clinic. So this ovulatory disorders, as you can see, 25% of the times, 1 out of 4 patients are because of anovulation, and this is where the chances of pregnancy are the highest through different techniques which the doctor uses for fertilization. So let us see a little more. Anovulation, as we just discussed, is when the ovaries do not release an oocyte during a menstrual cycle. Therefore, ovulation does not take place. 1 in 4 cases of female infertility are due to anovulation. And during the first 2 years after menarche, menarche is start of menses, 50% of menstrual cycles could also be anovulations. But thereafter, when a lady reaches around the mid-20s, 20s or the mid-20s, in a healthy person, in a healthy female, the anovulation would go down, and most of the cycles, menstrual cycles, will be ovulatory cycles. So from there gives rise to the infertility cases because of anovulation. Now, this anovulation has been classified, you can see in this particular screen, that WHO, that is the World Health Organization, has classified anovulation on the basis of the reasons. So, sure, you can see this. WHO, group 1. WHO, group 2, and WHO group 3. So based on the reasons of anovulation, WHO has classified it into 3 groups. So we have put a box on this, you can see here, hypogonadotropic, hypogonadism. No need to get confused with these terminologies. The seemingly complex terminologies actually, when we discuss, turn out to be very simple. Hypo means less than normal, hyper means more than normal. So hypo means less than normal. Gonadotropic comes from the gonadotropic hormones, that is GnRH, primarily FSH and LH. So you can understand less than normal level of the hormones leading to less than normal production of the ovum. So this hypogonadotropic hypogonadism basically refers to a female where the level of the hormones is also less, that is primarily the FSH is not sufficient. So you can understand if FSH is not sufficient, how will the follicle grow and how will it give a mature ovum. So obviously, and also if LH is less, the ovulation will not happen. So therefore, hypogonadotropic condition will lead to less than optimum release of ovum during the cycles. Next is normogonadic ovarian dysfunction, which means the level of hormones FSH and LH is normal. The potential of the ovary, the growth of the follicle inside the ovary is normal, but still the ovum is not being released. So therefore, normogonadic ovarian dysfunction, the primary causative factor comes out here to be PCOS. Then you have hypergonadotropic hypogonadism, which means the level of hormones, the level of FSH is more, but still the formation of ovum does not happen. So this, as you can see in the bracket, basically if the ovary does not contain proper number of follicles, ovary does not contain proper number of follicles, what will happen even if you give higher level of FSH? FSH will only work if viable follicles are there. If viable follicles are there, so you can see here, the level of hormones is more, but the production of ovum is less. So this basically is termed as ovarian failure. So basically, friends, WHO classifies anovulation, less amount of hormones resulting into less number of ovum, normal level of ovums, normal potential of ovum release, but still anovulation. And the third is high level of FSH and LH, but still ovum is not being produced. Now let us see, based on these 3 differentiating criteria, what stands the management of infertility. Now, once again, this slide may look to be very, populated, but no need to get perturbed up with this slide. So look at this. We are starting with 2 types of women. The first type of women with fairly irregular cycles. So apparently, this woman does not have any kind of problem till the time, of course, the couple tries to have a pregnancy but fails in having a pregnancy. Till that time, it looks to be a fairly regular cycle. The next is what? The next is oligoamenorrhea. Oligoamenorrhea means disturbed cycles. The cycles are long and they are very erratic. Sometimes the time period between 2 cycles may be reduced. Other times it may be prolonged. And it is presumed, medically, it is presumed that oligomenorrhea, a woman who has continuously oligomenorrhea for an extended period of time, will not be having ovulation. So this is medically presumed on the basis of clinical history and research. Now, if the woman is having a regular cycle, remember we had talked about mid-cycle progesterone estimation. So on day 22, if the level of progesterone is very low, it means corpus luteum has not formed. If corpus luteum has not formed, it means ovulation has not happened. So therefore, this gives an idea that it is an anovulatory cycle. High level of progesterone will mean ovulation has happened, but low level of progesterone on day 22 will mean ovulation has not happened. Now see, here also ovulation has not happened, and here also ovulation has not happened. So basically both these women, they end up with the same result. As a result of this, the infertility doctor will get into different types of evaluations and different types of tests with this person, with this lady. So FSH, prolactin, thyroid function test, progesterone challenge test, all these tests will be conducted. Now on the basis of the result of these tests, different results will be there. If the prolactin level is very high, prolactin is basically milk, it results in the secretion of milk after childbirth. But at the same time, after childbirth, prolactin level also prevents ovulation. So high level of prolactin without pregnancy, it basically means that it is suppressing somewhere ovulation, and it results in a particular definitive diagnosis. Then increased level of FSH, but decreased level of estrogen. E2 means estrogen. It basically means that estrogen is less, FSH is high, but still remember, ovulation is not there. So it basically means failure of the ovaries. So hypergonadotropic hypogonadism, which requires donor eggs. The lady is not having enough follicles in the ovary, so therefore an egg has to be taken from outside. Normal or reduced, now we are interested in these two cases, normal or reduced FSH and reduced estrogen level. Now tell me, what is the role of FSH? The role of FSH is to grow the follicles. If FSH level is low, how will the follicle grow? So can you understand, can you relate it? Hypogonadotropic hypogonadism. This itself means hypogonadotropic and hypogonadism. So this is a type of case which qualifies for assisted reproductive technique. Similar, normal FSH and E2 levels, estrogen levels. Once again, if still ovulation is not happening, again, this is hypo, less, this is normal, normo. Normo, gonadotropic and ovulation. So basically, these are the two cases, friends, which qualify for assisted reproductive techniques. And these are the two cases where we will see how letrozole comes into the picture and how it proves itself to be superior than other treatment option which is available. So, differential diagnosis. Based on this differential diagnosis, what are the three main approaches which come out in front of an infertility doctor? We are trying to make it as simple as possible. First is normogonadotropic, normogonadic. If you remember that normal levels of gonadotropic hormones, FSH, LH, normal potential, the reserve of follicle is not less, but still ovulation does not happen. If you remember, PCOS was one of the major reasons here. So we have to reduce estrogen level. If you remember, what does estrogen do? It gives a negative feedback to the hypothalamus and the pituitary, and it further reduces the production of FSH, which results into anovulation. So anti-estrogens basically are drugs which will reduce the effect of estrogen on the ovary. So therefore, if the effect of estrogen on the ovary is less, on the pituitary gland is less, FSH release will be more, growth of follicle will be more, the chances of ovulation will be more. So one drug which classically has been used is clomiphene citrate. Tamoxifen, but not much used. So the major drug which comes out here is clomiphene citrate. We have not put our drug here because now the role of letrozole versus clomiphene citrate will come up, which we'll discuss in a few minutes of time. The second option, this is monotherapy. The patient is given only and only clomiphene citrate. We will discuss how. But if only clomiphene citrate does not work, at times, along with clomiphene citrate, the second line treatment is exogenous administration of FSH, and HCG can be used in or as an alternative to FSH. Now this was normogonadic infertility. We go to hypogonadism. The level of FSH, LH is less, because of which the ovum is not produced. Now look at this. If the level of FSH and LH is less, you can understand that obviously FSH and LH has to be given from outside. So this is basically ART, assisted reproductive technique, or it could also be normal cases without intervention where FSH and LH is given from outside. The third case that we are seeing is insulin sensitizers, basically PCOS cases where insulin sensitizers are given, metformin, 500 milligram BID or TID, given for almost 5 to 6 weeks of time. And of course, weight loss and exercise. Remember here that why metformin, we would feel that is not indicated anyway for infertility, and it is not indicated for infertility. Basically, it is an insulin sensitizer, which increases the utility of insulin in the peripheral tissue of the body, therefore reduces the quantity of insulin in the body. Insulin is basically, if the insulin level in the body increases, it basically reduces the sensitivity of the follicle growth, and which leads to anovulation. Fine. So what are the shortcomings of the existing therapy? Number one, not many treatment options are available. Clomiphene citrate classically has been used mostly in this case. So although conventional regimens are still in use, new modalities have been developed that may open up new methods in the treatment of anovulation. And this is where we are focusing with letrozole. No consensus regarding algorithm for use of infertility treatments in daily practice, and success rate is very closely tied to the age and overall health of the patient, and success rates can be very low. So do we have a solution where we have a more definitive solution to this, which increases the rate of ovulation and which also increases the rate of pregnancy in infertility cases? So friends, that brings us to our molecule, letrozole. So let us see what is the class and mode of action of letrozole, what is the place in therapy, how is it superior over competitors, and what are the key clinical trials which prove the superiority of letrozole over other drugs. Letrozole is an aromatase inhibitor. It's a third generation compound. So what is an aromatase inhibitor? If we understand this briefly, aromatase basically, let us talk of this. In the next slide, it will be more easy to understand what is an aromatase inhibitor. There are 3 generations of aromatase inhibitor: first generation, second generation, and third generation. And letrozole belongs to the third generation of aromatase inhibitor. The name of the innovator molecule is Femara. It's a 2.5 milligram oral tablet. Now look at this. What is aromatase? Aromatase is basically an enzyme which is present in the human body, which converts androgens into estrogen. Remember, what is the role of estrogen in the female reproductive cycle? It produces a negative impact. It gives a negative feedback to the hypothalamus and pituitary. Therefore, the pituitary gland reduces the production of FSH, less growth of follicles, which may lead to anovulation. So what do we need to do? We basically need to prevent this estrogen from working. So what does letrozole do? It blocks the action of this aromatase. Therefore, it blocks the production of androgen to estrogen. With less quantity of estrogen, what will happen? The suppression of the pituitary will not happen. The pituitary will continue to produce FSH. That will continue to act on the ovary. That will continue to lead to the growth of follicles. So therefore, the chances of anovulation are reduced and the chances of ovulation are increased. So I think with this much of understanding, now it would be very easy. The overall picture would have become very clear. And now we can go and discuss the molecules, go deeper into the aspects of the molecules. Okay, so this is what is deactivated. So therefore, the suppression of this step is not there. What are the pharmacokinetics? Pay close attention. Very important, because these ultimately will come out as the benefits of letrozole over clomiphene citrate. The bioavailability is close to 100%. Plasma protein binding is significantly good. And look at this. This you will see is a major benefit. Number one, whatever dose you give is entirely utilized. And number two, the terminal half-life is 2 days. What does this mean? It means that when letrozole is stopped, 2 days after letrozole is stopped, the effect of letrozole is finished and it does not have any prolonged effect on the body. This would be very, very important when we go into the details. So basically, when we talk of infertility, the low role of letrozole is what? It causes ovulation in anovulatory infertility, both as monotherapy and in conjunction with other gonadotropins, that is FSH and LH, as well as in PCOS-induced infertility. The dosage is 2.5 milligram, one tablet of 2.5 milligram once a day, regardless of a meal. So therefore, it can be taken any time of the day, preferably at the same time every day. The dose can be increased as per required, but generally in infertility, a dose of 2.5 milligram is the one which is required. Now, we had talked about three treatment modalities in infertility. Let us see how letrozole fits into each of these treatment modalities. Now, look at this. For induction of ovulation in anovulatory infertility, monotherapy as a first-line treatment, the recommended dose is 2.5 milligram tablet once a day from day 3 to day 7 of the menstrual cycle. So this line represents from day 0 till day 28. Ovulation will happen on day 14. So therefore, letrozole is given from day 3 till day 7. So what is being done here? Estrogen is being suppressed. When estrogen is suppressed, the pituitary continues to secrete FSH, and therefore the growth of the follicle is more stronger, and the chances of ovulation on day 14 is stronger. So this is monotherapy. Second line is in patients who have been already tried with clomiphene citrate. CC stands for clomiphene citrate. Clomiphene citrate has already been tried in previous infertility cycles in the woman and with failure. I mean, it has not led to pregnancy. So even in CC resistant women, letrozole can be tried as a monotherapy. Same dose schedule, same way of using letrozole. Let us take one more case in combination with gonadotropin. So where you would see that it is hypogonadotropic. Hypogonadotropic means the patient does not naturally produce enough quantity of FSH and LH. The way letrozole is used does not stop. You can see here, letrozole is used same from day 3 till day 7, 2.5 milligram tablet once daily without regard to meals. Now, once what happens is the natural production of FSH of the body is maximized, and day 7 onwards, HMG is given 75 IU on alternate days starting from day 7 till 10 days or till the primary follicle, the dominant follicle, achieves a size of 16 to 18 millimeter. So that maximizes the chance of ovulation. A significant difference in this particular protocol, a significant difference between letrozole and clomiphene citrate. You can see here, HCG dose with letrozole was 75. But when CC is given, clomiphene citrate is given, a higher dose of HCG is required. So basically, you can very well understand that lower the requirement of hormone, better are the pregnancy outcomes, and better is the tolerability profile for the patient. So therefore, you will see here that comparatively, letrozole makes it more easy for the ovary to ovulate as compared to CC. PCOS, same, letrozole usage remains the same, and metformin usually is continued, as we talked about, is usually continued for about 6 to 8 weeks of time to reduce the insulin resistance in the body. So therefore, you will see that whatever be the protocol, whether monotherapy or with gonadotropins or with metformin, the way letrozole is used remains the same. So therefore, single protocol, same way of using, same dosage, different protocols, different profiles for the patients. Contraindications: hypersensitivity to letrozole, abnormal uterine bleeding, uncontrolled thyroid or adrenal function, intracranial lesion like pituitary tumors, pregnancy and lactation. Nothing much. Every doctor would expect and accept these contraindications. Special populations: renal, mild to moderate renal impairment and hepatic impairment. No dosage adjustment is required. Only in case of cirrhosis and severe hepatic dysfunction, the dosage should be reduced to 50%. So therefore, fairly easy to use and with a very good safety profile. What are the advantages of letrozole? See, we have already discussed this. I'll point out to a few things once again. Extremely potent in inhibiting aromatase enzyme. Basically, the difference between letrozole and CC. How does CC work, clomiphene citrate work? Letrozole reduces the production of estrogen. Clomiphene citrate does not reduce the production of estrogen. It blocks the estrogen receptors on the pituitary. So as a result of this, with CC, the production of estrogen will still be there. When estrogen will remain inside the body, it will not bind with the estrogen receptors. The quantity of estrogen in the blood will increase, and that may have harmful effect on the human body. So you can understand that letrozole is one step further. It reduces the production of estrogen, and therefore it prevents the accumulation of estrogen in the body, and therefore the negative effects which are seen because of estrogen accumulation are not seen with letrozole, leading to a better safety profile over clomiphene citrate. So 100% bioavailability, rapid clearance from the body. You can see the half-life of clomiphene citrate is 2 weeks, and it takes about 6 to 8 weeks to clear from the body. So obviously letrozole with a short half-life will be much not only safer, but it also does not interfere with other metabolic processes of the body. No accumulation, no significant metabolites, well tolerated, few side effects, very safe without contraindications, and it is quite economical for the patient's pocket also. Anastrozole, just making you aware of anastrozole. This is not a big competitor. It's once again a third generation aromatase inhibitor, just like letrozole. Anastrozole also tried to create a market, but it does not have significant data. It does not have the clinical trial pool, and the clinical trials, whatever are there, did not show the same results as that with letrozole. So letrozole has significant better ovulation and pregnancy rate as compared to anastrozole. So this is the major talking point for letrozole. Today, the primary drug which is being used is clomiphene citrate. With letrozole, there are superior results to letrozole. It does not have the anti-estrogenic side effects. We just talked about this. Lower serum estrogen concentrations. Reduced dose of FSH is required. So reduced dose of FSH is much better for the patient, and it also reduces the risk of OHSS, which is ovarian hyperstimulation syndrome. It improves the response to FSH, and CC is also known to decrease the uterine blood flow, which isn't the case with letrozole. So if uterine blood flow means if endometrium gets less blood flow, the quality of endometrium will not be good, and it will not be able to hold the fertilized ovum for a proper pregnancy. But letrozole does not reduce the endometrial blood flow, therefore the pregnancy outcomes are better, and the live birth rate is higher as compared to CC. And then we talked about the half-life. So once again, quickly summarizing, anti-estrogenic effects, letrozole does not have, clomiphene has, because of the accumulation of estrogen, which is not happening here. Ovulatory cycles, remember, this is a big benefit with the letrozole. Clinical literature has suggested that letrozole leads to more mono-ovulation as compared to multiple follicle development in clomiphene, which obviously is always a desired outcome of infertility treatment. Endometrial response is better. We just discussed that clomiphene reduces the blood supply to the endometrium, while letrozole does not. Combination with metformin, higher number of follicles with letrozole as compared to clomiphene. Pregnancy rates with letrozole are higher, and no anti-estrogenic effects because of accumulation of estrogen. Now, a very interesting point. Remember, in the beginning of our discussion, Mr. Rakesh Gupta and Ashish also talked about that letrozole, we used to have letrozole in our product basket, and it was a good product, but somewhere in 2012, in India, letrozole was banned in pregnancy infertility cases, citing teratogenic effects in the humans. Now, 2012 and 2017, we are 5 years down the line. Those of us who are experienced with promoting letrozole, how many of us missed letrozole in the last 5-6 years? I'm sure everybody. But the good news is there has been clinical trials done, and based on these clinical trials, all the claims of teratogenic effects have been cleared. And as you can see, there are different clinical trials that we are quoting here. No difference in overall rates of major and minor congenital malformations as compared to CC treatment. Look at this. Letrozole stimulation reduces the risk of miscarriage with no increase in major congenital abnormalities or adverse pregnancy or neonatal outcomes compared with natural cycles. So therefore, added advantage. And no significant difference in the overall rate of congenital malformations among children as compared to CC. So therefore, there have been clinical trials, latest clinical trials, 2014-17, Indian clinical trials, which clearly mentions that all the risks that were perceived were not on solid grounds, and they have been proved to be wrong. So 2017, all doubts have been laid aside, and the DCGI has cleared letrozole for infertility usage once again. So that brings back the product with a bang in the market. So see, enough of not only this. Do guidelines suggest? Which are the two biggest guidelines? I'm sure you will talk about Indian, FOGSI, international, ACOG. So I'll show you both. Look at this, American College of Obs and Gynae. For women with polycystic ovarian syndrome and a BMI of more than 30, letrozole should be considered as first-line therapy or ovulation induction because of the increased live birth rate compared with clomiphene citrate. FOGSI, aromatase inhibitor letrozole.
Is that then BMI more than 30 in the sense obese mostly?
Yeah. There's an addition here. Dr. Abhay mentions here that BMI more than 30 basically means obese women. And we know that PCOS and obesity go in hand in hand, and has to be addressed. So FOGSI, once again, letrozole may be used as alternative first-line treatment. So friends, you notice here, both ACOG and FOGSI are stressing on this word, first line, which means it is very much suggested that letrozole be replaced with, replaces clomiphene citrate as ovulation induction drug. So therefore, the target for letrozole basically becomes those doctors who are prescribing clomiphene citrate. So clinical evidence, we'll have a look at this also. Look at this. Clinical trial with 64 anovulatory patients with PCOS, given letrozole versus clomiphene citrate for 5 days. Primary objective is to study the rate of ovulation and pregnancy. The results suggest that with letrozole, there is 62.5% patients who have ovulated, and with clomiphene citrate, there is 37.5% patients who have ovulated. Look at the pregnancy rate. The pregnancy rate with letrozole is 40% compared to 19% with clomiphene citrate, which is more than double. And that itself shows the superiority of letrozole over clomiphene citrate. Now versus anastrozole also, as though we said that this is not very important. anastrozole does not have a very big market, but still, if you come across this question versus anastrozole also, there are clinical trials where it suggests that this is the ovulation rate with letrozole and this is the ovulation rate with anastrozole. So very clear it is superior, as well as the rate of pregnancy is superior with letrozole as compared to anastrozole, which again is almost double. Then there is one more indication which is of interest, letrozole in young women with unexplained infertility. This is a trial which was done in Egyptian women, and you can see here that letrozole, the success rate is much, much higher. It's almost close to 24% as compared to clomiphene citrate, where it is just about 11%. So adverse events, if we talk of with letrozole, mild to moderate, joint pain, hot flushes, nausea, fatigue, headache, and backache. So this is nothing much compared to clinical practice. So what are the salient features of letrozole? It's a third generation aromatase inhibitor indicated in ovulation induction, superior to clomiphene citrate, useful as part of assisted reproductive protocols to induce ovulation in infertility due to endometriosis, PCOS, unknown causes, and it is well tolerated. So gentlemen, the biggest market lays ahead, as we discussed, is clomiphene citrate. So let us have a look at this once again before we hand over to Saurabh for the marketing session. Letrozole is a aromatase inhibitor, whereas clomiphene citrate is an estrogen receptor antagonist. Letrozole has a half-life of 48 hours, whereas clomiphene citrate has a half-life of 2 weeks. The biggest benefit of letrozole, it blocks the conversion of androgen to estrogen. Therefore, it reduces the overall quantity of estrogen in the human body. Whereas clomiphene citrate only blocks the estrogen receptor, so leads to the accumulation of estrogen with long effects. 2 weeks half-life. So therefore, the accumulation of estrogen in the body is very high. And this leads to supra-physiological estrogen. Supra means more than normal estrogen levels, which certainly will be harmful for the human body. And here, the estrogen levels are maintained within normal limits, and therefore, you don't see the side effects which are seen with clomiphene. Less chances of ovarian hyperstimulation syndrome because the dose required of FHS, follicle stimulating hormone, is less with the letrozole as compared to that required with clomiphene citrate. No deleterious effect on endometrium. Why? Because it does not reduce the blood supply to the endometrium. But clomiphene reduces the blood supply to endometrium. Therefore, it may lead to thinner endometrial lining, which may adversely affect the outcome of pregnancy, and which is very clearly seen that the pregnancy rates with letrozole are much higher than that with clomiphene citrate. So, better pregnancy outcomes with letrozole as compared to clomiphene citrate. The choice is yours, friends. Which product would you like to have in your basket, and which product would you like to take to your doctors?
ये है क्या? नहीं।
Okay. Okay, we have a few questions which are coming up. I am sure most of your questions would already be answered during our discussion. We have a few questions, so let me speak out these questions. What is the scope of letrozole in gynecology? Friends, there are two major indications of letrozole. One we have already discussed is ovulation induction. The second indication of letrozole in gynecology is its usage in breast cancer. But of course, in our product basket, we are having letrozole for the infertility indication. Which type of infertility is it used? Primary infertility, and we have already talked about the three WHO classifications. So basically, letrozole can be used as a monotherapy in unexplained infertility cases, in patients who are on PCOS, and also in patients who are requiring assisted reproductive technique, FSH and LH, to be given exogenous. Remember here, a big market would be a gynecologist who diagnoses infertility for the first time. The first approach in pregnancy by these doctors, and this is the biggest pool of doctors, the first approach is to increase the normal production of the endogenous production of FSH. So therefore, the first approach is to give ovulation induction drug to the patient to try and see that without any other kind of intervention, just by giving an ovulation induction drug, the patient gets pregnant. So that is the biggest pool where letrozole fits in very, very nicely. Next question is, what is the half-life and FDA approval? Half-life, as we talked about, is about 45 hours, whereas with the clomiphene citrate, it is 2 weeks. FDA approval, letrozole has FDA approval for usage in breast cancer, but as of now, it does not have US FDA approval for infertility, but it is DCGI approved, and the approval of DCGI is based on the different clinical trials. And also remember one more thing, that when we talk about the guidelines, both FOGSI and ACOG, which are the biggest dependencies by a gynecologist and infertility doctor, both of these bodies they recommend. Can doctor prescribe progesterone along with letrozole, and in what dosage? Basically, if you look at the time period when letrozole and progesterone is to be prescribed, letrozole is going to be prescribed day 3 to day 7 in a cycle, and day 3 to day 7 is pre-ovulation. After that, the ovulation will happen, and only if successful ovulation happens and the ovulation test is positive, generally progesterone is started on day 17 for maintenance of pregnancy. So therefore, you would understand that the time period for the prescription is different. So usually a co-prescription of letrozole and progesterone will actually not be required. CC versus letrozole mode of action. Friends, we have already discussed this. CC suppresses, is a estrogen receptor antagonist, while letrozole reduces the production of estrogen. That is the biggest difference, where the physiological effect of increased estrogen is not there with letrozole, and that comes out as a very big benefit of letrozole over CC. Then HCG dose with the letrozole, we have already seen that the dosage of HCG required with letrozole is comparatively less as compared to CC. The dosage is on an average 75 compared to 200 with CC. That is one more benefit, because with lower exogenous usage of gonadotropins, for the patient it is better tolerable, and the chances of ovarian hyperstimulation syndrome is also reduced. So these were the major questions which came up. You can still keep on putting your questions. Even after the launch, if you have some questions, you can refer the questions to Saurabh, and we can always ensure that you get the answers to all your queries.
I just would like to add in this last question of HCG, maybe all of you are confused that around 75 IU and 200 IU, which is given in the slides. But the present dosage which are present in the market is 2000 IU, 5000 IU and 10,000 IU. The particular study which is shown over here is a study which is carried out with a controlled environment and with a specific purpose. That's why they calculated on a smaller dosage. Take home message for us for HCG dosage is, with letrozole protocol, the requirement of HCG will be less. Like for example, doctors are using 10,000 IU for trigger. In this case, doctor has to use only a 5000 IU, that is enough. There are some studies which are also present which says that with the letrozole, requirement of HMG and FSH is also less. In short time, or maybe in some time, we will share all these studies with you. Fine. So I think we will start marketing presentation over here. I would like to give thanks, Rakesh sir, that you summarized this product very well. A good piece of marketing medical presentation. Thank you. Thanks a lot.
Thank you.
And this presentation is prepared by Abhay also. So thanks, Abhay. So we are starting marketing presentation now. So all of you know that sometime environment becomes cloudy, and at that time we need to wait. Here I am referring that in 2011, when this molecule got banned, this environment becomes cloudy, and we have to wait this 6 to 7 years because of ban. And once the cloud of uncertainty is vanishes, a smile of confidence restores. So presenting, friends, Lutrozole, the confidence restored with the Lutrozole. Before going further, we would like to see a market data. So let's see interesting numbers. What market say? What are the market number? What is the growth? And what are the prescribers are doing? Sorry, what are the competitors are doing? Let's see. So this is a market of 35 crores. I think Rakesh sir has mentioned this at the very beginning, that this is a market of 35 crores, and this is growing with a phenomenal growth of 140%. So let's see, let's dig further the market data. This is the market data of from 2010 till 2017, and we have plotted Lutrozole annual total and Clomifene annual total. So in 2010, Lutrozole was a 44 crore market and Clomifene was a 21 crore market. That means Clomifene was a smaller market than a Lutrozole. Going way forward in 2011, again it got a huge growth of 56 crore and Clomifene is on the same number, that is 21 crore. But in 2011, so as Lutrozole is banned, Lutrozole sale is went down drastically, and because of Lutrozole loss, it is a Clomifene's gain. Consider in the situation, if that ban was not there, this market would have been a 200 crore till now. So what is the take-home message? The take-home message is market is going to double up in short while, maybe at the end of this year. Let's see now a prescriber data. In 2010, 13,000 prescribers were there with Lutrozole and 18,000 prescribers were there with Clomifene citrate. And so as it is banned, come in between, Lutrozole prescriber went down drastically. In last year, it was 890 prescribers were there only, while in August 17, right now, it is 3,489 prescribers. So what is the take-home message? The take-home message is there is a scope of adding around 17,000 more prescribers to Lutrozole. So some of you may be seeing that there are around 10 to 12 or around 30 Lutrozole brands are there in the market, and we are launching late. So there is no worry. There are again around 17,000 prescribers are going to add in this market. Here we have an opportunity to prove ourselves. Now see a competitor insight. The competitor insight, let's see, Lutrozole and Litovel, these are the two brands from Sun Pharmaceutical, are acquired around 55% of a market share. It is by only one company. All brands, if you can see this having a great growth. It is only because the ban is just lifted in years ago. That's why all brands are showing growth, and market is also showing 140% of growth. Let's see a prescriber base. This is a interesting data. Now prescription Lutrozole is showing around 385% growth. For prescriber, market is showing around 292% growth. I want to show you, drag your attention to PYD data over here. PYD of Lutrozole market, it is around 20. So 20 prescriptions are coming from each doctors. If you see, other brands which are getting how much PYD? It is around 16, 18, 26, 27. So for some brand it is 23. That means PYD is revolving around 20. That means all brands have their fixed prescribers. So it is not like that competitors are eating each other's market share. It is not like that. Every brand has their own market, own prescribers. So, and if you correlate that around 70,000 prescribers are going to add in some period, that means we have a scope for creating our own prescriber base. So what is the market data summary? So Lutrozole market did not get an opportunity to grow because of intermediate obstacles. As I cleared in 2 slides back, that if that ban would have been not there, this market would have been around 200 crore. Market will reach around 60 crore in a short while. That means market is going to double up. And around 75% of gynecologists will prescribe Lutrozole. As I have cleared you, that around 70,000 doctors will start prescribing in short while. So if we consider the universe of 26,000 gynecologists, so around 22,000 gynecologists will, if they start, around 75% of gynecologists will prescribe Lutrozole, and 75%, friends, is a handsome amount of share. So all competitors, last point is all competitors have their respective prescriber set that we have saw with the PYD data which I have shared with you and just in last slides. Now, what are the target customers for us? So, in launch, you expose to all gynecologists. Lutrozole, as we are launching again, it was our old brand. So, we inform all gynecologists that yes, we have come back with Lutrozole. So, expose to all gynecologists. You target only 20 doctors, and out of these 20 doctors, you focus only on 10 gynecologists. Now, how you are going to focus on these 10 gynecologists, or how you are going to identify these target 20 doctors? I am sure that pre-launch survey is going to help you in this customer selection. So this is the format which is shared you on 18th of October this month, and I'm sure that you are working on it and hope this format is ready to be executed. So this is the format which I shared with you. So with the help of this format, we need to identify the customers, which are the clomiphene citrate prescribers, which are the competitor brand prescribers, like who is prescribing Litros, who is prescribing Litovol, who is prescribing Intas brand, and other competitor brands. Now, finally, who are the target customers? The target customer first you're going to target is Lupin's customer, the doctors, those who are already with us, doctors, those who are already prescribing for us, near and dear prescribers of Lupin. We need to go towards them. They will start prescribing our brand, that is Lutrozole. Second customer set that we are going to target is a CC user, that is clomiphene citrate users. Those who have prescribing clomiphene citrate but they are not yet started Lutrozole, we are going to promote this CC to them. Then third is Lutrozole prescribers, those who are already prescribing Lutrozole, competitor brands. We are going to promote to them Lutrozole to these prescribers. So what is the place in therapy? We already saw right now medical presentation. Let's go through a rough idea of a market. First line therapy, usually doctors are using clomiphene citrate. If they are not getting success, then they shift to gonadotropins like HMG and FSH. If they still not get the success, they will go to gonadotropin, that is recombinant drugs. Now, your Lutrozole will play a role over here for first line therapy, that is, it is going to replace clomiphene citrate, as well as Lutrozole. If doctor can club with gonadotropins like HMG plus Lutrozole protocols are there, FSH plus Lutrozole protocols are there. So in two places, doctor can replace Lutrozole. First one is at the place of clomiphene citrate, and second one is gonadotropin plus Lutrozole. So let's go forward. So now what is the approved indication? The approved indication for a lutrazole is ovulation induction in anovulatory infertility and PCOS. So what are the, let's see a competitor insight. Now these are all the brands and these are the companies. Now we have shared MRP of each and every brand over here. So roughly around MRP is between around 187 to 160. The band price of in between 160 to 187. This is the MRP of all the brands. Now this is the pack and price of lutrazole. I am giving you some time to note it down. This is a pack and price of lutrazole, that is our brand. This is a pack size of 1x5. This is a 5 tablet strip. It comes under 12% GST slab. MRP is 1,986 rupees and TP is 1,418 rupees. Fine. Now let's go for communication. We are not going to launch this product with visual aid. This time we are going to launch this product with gimmick detailer. You are going to get a normal visual aid, that is in next cycle, which is upcoming cycle in December. Till the time you are going to promote this product with gimmick detailer. So this is a first slide of gimmick detailer. How gimmick detailer is going to work? After end of this detailer illustration, I'm going to demonstrate how it is going to work. I'm going to share you a video clip. So for you, it is difficult to say no. So doctor, for you, it is difficult to say no. You will agree with me. If IVF cycle fails or any first line cycles also fails, it is difficult for doctor to convey that no, this time it is not possible. This time it is, this cycle particularly that we run, it is failed. So you are telling doctor, for you it is difficult to say no. So limited first line therapy option for ovulation induction, doctor, restricts your success. So limitation of present therapy keeps you away from success. So what is the limitation of present therapy? Present therapy is a clomiphene citrate. Here we are targeting clomiphene citrate. So doctor, clomiphene citrate, because of clomiphene citrate there is a thin endometrium lining. Because of clomiphene citrate, it accumulation in the body for a long duration. Clomiphene citrate, because of clomiphene citrate there is a compromised pregnancy rate, and because of clomiphene citrate there is a multiple follicular development is there. To address this, doctor, introducing lutrazole, the confidence restored for ovulation induction in anovulatory infertility and PCOS. Now choose the option for assured success. Now doctor, prescribe lutrazole, restore confidence, restore success. Doctor, lutrazole offers thick endometrium and favorable cervical mucosa. With lutrazole, it does not accumulate in body because of short half-life. Lutrazole offers higher pregnancy rate and lutrazole offers monofollicular development. So as you saw in the medical presentation, these are some of the important points. These important points we are going to highlight in your gimmick detailer. So here also we have mentioned dosage that is 2.5 milligram once a day from 3rd day to 7th day of menstrual cycle. Now at the end of this gimmick detailer we are sharing lutrazole is recommended by authority. As you saw in the medical presentation, yes, this recommendation came from Foxy and ACOG. We are sharing this recommendation, like from Foxy, lutrazole may be used as a alternative new first line treatment for ovulation induction in anovulatory infertility. Who says this? This is said by Foxy. Now what ACOG says, lutrazole should be considered as a first line therapy for ovulation induction because of increased live birth rate compared with a clomiphene citrate. So two recommendations we are sharing over here. Now we are going to share you how this gimmick detailer is actually working. Now you can see, now you can pull this apart and one by one slides will come up.
Detail one page and pull further.
Detail one page and pull further. Detail one page, like see, when you pull this, one slide will come, you detail and go for a second page. Detail second, go for a third page. Detail third, go for a fourth page. Now this is how you are going to,
Last one.
and last one page is for recommendation.
Okay.
Now we are giving you a chemist availability card as a reminder card. Objective of this chemist reminder card is to emphasize on brand reminder and the availability of product. Most of the time, the success of the product which depends on the doctor's prescription, and most of the time doctor refuses. Why? Because they say it is not available nearby chemist. That's why I am not rude. So whenever you will get this chemist reminder card, you just, after the availability of letrozole in nearby chemist, mention the name of chemist and hand over to doctor as a reminder. So allocation, we have allocated 20 per ME. We have giving you enough amount of this chemist availability card. You are going to give this cards on visit 1. Second one is a scientific update, that is a product monograph we are giving you to provide all scientific updates regarding the product. Allocation will be 20 per ME, and this is also you are going to give on visit 1. Third is samples. Objective is to create a strong brand reminder with a full treatment of sample of 5 tablets. So as this strip and treatment duration is 5 days and the dosage is once daily, actual requirement is 5 tablets for 5 days. So there is no fun in giving 2 tablets for the doctor. So we are converting some sales strip to the samples. Allocation is 30 per ME. Especially for launch, we have converted 30 strips per ME for cell, from cell to sample. So distribution will be 3 per doctors, only for 10 focus doctors, that we have decided that we are going to expose to all. We are going to target to 20, but we are going to focus to 10 doctors. For these 10 doctors, we are going to give this samples. And this is also, we are going to give them on visit 1. Now brand reminder, that is a chit pad. Chit pad, again the objective is emphasize on brand reminder. Allocation is 20 per ME. This is sort of unique chit pad we are going to give you. This will remain on a doctor's table because we have segregated this chit pads in important, notes and urgent, sort of like this, so that doctor would like to keep this on his or her table. You are going to give this on visit 2. Again brand reminder, that is chit pad, emphasize on brand reminder. This is not only a brand reminder. You can see over here with the chit pad and pen holder, this input will have a letrozole protocol cards. You can see over here, we are going to give you a protocols. One protocol we will give you, that is letrozole monotherapy. That means only a letrozole protocol. Maybe second protocol we will give you letrozole plus HMSU protocol. Third protocol we will maybe give you letrozole plus metformin protocol, that is in the PCOS. So different 3 protocols we will give you. So this will remain on doctor's table. Utility of this input is increased because of we are providing protocols along with this chit pad holder. So allocation will be 10 per ME. Now who's this 10 doctor? Again, these are the focus 10 doctors. Only 10 focus doctors. This is we are going to give you you are going to give doctors on visit 3. Now this is a 3-visit plan. So we win, that is visit 1, you're going to detail with gimmick detailer. Then you are at the same visit, you're going to give them a chemist availability card. On the same visit, you're going to give them a product monograph, and also you're going to present them as samples. In visit 2, gimmick detailer and chemist availability card will remain as it is. You're going to add chit pad. In visit 3, we are going to give you one LBL. Now this LBL we are going to design in such way that this letrozole is got a ban from in 2011, and this ban is lifted on around 2017. So we are going to provide you studies between 2011 to 2017. So to emphasize more the confidence. So as our theme for this product is restore the confidence. To restore that confidence, we are going to provide this LBL to you. And visit 3, letrozole product come tabletop reminder that I have just shown to you that we are going to give you in visit 3. Now, all India launch date is 9th November. Most of the territories, I suppose you have built letrozole, but still you do survey for next week, and all India launch date will be 9th November. Unanimously, we are going to launch this brand on this date only. Fine. Till the date, you will receive all the inputs which I have shown to you. So that on visit first, you can detail with the gimmick detailer. You can able to give chemistry availability card. You will get the product monograph and samples too. So for first visit, you have all arms and ammunition for your first visit, and you can bombard all these arms and ammunition in very first visit to get the success. Fine. So what are the points to be emphasized? These are the important points which are already covered in a medical presentation, but we have to more emphasize on these points. That is, it on anti-estrogenic effect parameter, letrozole doesn't show any anti-estrogenic effect, while in case of clomiphene, yes, it is showing anti-estrogenic parameter. Because of anti-estrogenic effect, endometrial lining is not compromised with letrozole, but it is compromised with clomiphene. In ovulation cycle with letrozole, there are monoovulation, monofollicular development is there, but with in clomiphene citrate, there is a multiple follicular developments are there. Endometrial response with letrozole is better due to improved vascularization, but so as anti-estrogenic effect is there with clomiphene citrate, the vascularization is poor and there will be inferior response. When it will be combined with metformin, letrozole give higher number of follicles, while in clomiphene citrate, less number of follicles with there when it is combined with metformin. Pregnancy rate with letrozole is higher and pregnancy rate with clomiphene citrate is lower. And high supraphysiological levels of estrogen leading to adverse outcome. It is no with letrozole because it doesn't exhibit anti-estrogenic effect. It just inhibits the conversion of androgen to estrogen by inhibiting aromatase. While in case of clomiphene citrate, yes, it is having, it exhibits high supraphysiological levels of estrogen because it blocks the anterior pituitary estrogen receptor completely. That's why estrogen secretion will be completely blocked, and that's why compromised endometrial lining will be there. So these are some of the important points that we need to emphasize during launch, during our conversation with doctor. Understand? Fine. Let's see what is the objective. According to you, what should be the objective? Let's calculate. So one doctor bare minimum is 20 p/d at the time of prescriptions. When I showed you p/d of a market, it is around 20. That means one doctor is prescribing around 20 prescription, And at the same slide, I have explained you that is all brands have there is a respective prescriber base. So around 17,000 doctors needs to going to prescribe this letrozole. So around if they prescribe 20 prescription for us, so 20 patients means 20 prescription. 20 prescription is equal to 2 boxes. This is a very straightforward. So 2 box per into 10 doctors. So as we are going to focus only on 10 doctors, 2 boxes per into 10 doctors, that is 20 boxes. So 20 boxes will give you a value of 28,378 rupees, precisely around 30,000 rupees business you're going to get from these 20 boxes, that means from 10 doctors. Let's calculate further. So 20 boxes into 320 field force which is there with our Phoenix division, that is 6,400 boxes. If we multiply this 6,400 with the TP rate of 1,418, 90 lakh rupees will be there. That means this brand will become 90 lakhs rupees per month, and 90 lakhs into 12 months will become around 11 crore brand in first year. So objective for this brand for first year is around 11 crore in first year, but objective at your level is a 20 box per head. And I think this is a very minimal objective, because I can see your response which is coming towards me with the help of WhatsApp. We are getting on each day there are 10 box booking, 5 box booking from one doctor, 15 box booking, and I can see, and 3 days ago somebody is booked around 20 box from one doctor. So you can see the potential of this product. One doctor can support you 20 boxes, but still you focus on 10 doctors, and from these 10 doctors we want a support of 20 boxes. So thank you from my side and all the best for the launch. You launch on 9th November so that all the inputs will come towards you, and you launch with the full-fledged arms and ammunition. This is I got an opportunity to connect with all 320 medical representatives, all AMs, all RSMs on one platform. This is a great privilege for me. Best of luck for all of you. Now I'm handing over session again to Ashish sir, so that he can sum up and moderate the session further. Thank you. Thanks a lot.
Just before me speaking on the closing remarks, I have seen that there are a couple of more queries, medical queries, and there are certain marketing queries as well, which we received. I now want Rakesh and Abhay both to take care or to handle all these specific medical queries. After that, I'll discuss some of the medical queries as well.
Now Abhay is also joining us. So I think from the beginning he is not there in picture.
Hello, everybody. I hope I'm audible. This is to answer some questions regarding the medical stuff. So I can see here the first question is the role of letrozole in PCOS. So basically, PCOS has its own different treatment, and PCOS is a different entity. So letrozole is not going to treat PCOS. Basically, let's be very clear on that. When we talk about PCOS, we are going to help the woman with PCOS to conceive, right? We are treating her infertility, which usually goes hand in hand with PCOS, but we can't give letrozole to treat PCOS. So let's keep that aside. It's a very big phenomenon, the entity disease in itself.
Role of letrozole remains the same. It is basically ovulation induction. So it is not a treatment for PCOS. PCOS induced anovulation. Letrozole is an add-on treatment.
Sure. Great.
See, please try to understand. Our main indication is unovulatory infertility. So unovulation, it may be because of, there are several reasons for unovulation, and PCOS is one of the main reasons of unovulation. Understand? That's why it is important to have a PCOS as a bold indication. to promote its product.
Okay, then what I see here is the second question, which is how long, for how many cycles in infertility? So see, there is no clear-cut indication or cutoff that you can prescribe it for this many cycles. But you also, when you compare with clomiphene citrate, what you see is in clomiphene citrate, usually positive results are expected in around 6 to 8 cycles, and sometimes it goes on till 10, 20 cycles. I think with letrozole, there is not a statistical significance between these two, but you can expect results earlier, maybe in just 3 to 4 cycles. I would also like to add an important thing that infertility is a very big issue. I mean, it is a very multifactorial thing. So it not only depends on your treatment, but it also depends on all other factors. And there is a woman's husband who is also involved. So nobody can give you guarantee in these many cycles you get results, right? But you have to be you have to keep in mind that there is no cutoff for cycles. You have to give 4 cycles and stop it. No, you can continue the cycles unless and until they achieve success. The couple achieve success.
I would like to add some practical experience from the doctors. For clomiphene citrate, actually 3 to 4 after a 4 cycle, doctor usually say don't give clomiphene citrate after 4 to 5 cycles. Maximum threshold is 5 to 6 cycles, because in the case of clomiphene citrate, there is a possibility of ovarian hyperstimulation. More you use clomiphene citrate, your ovarian store will drain as fast as it can. So clomiphene citrate, 4 to 5 cycles are enough. Theoretically, yes, what Abhay said is correct. Yes, doctor can go to 5th or 6th cycle also. In case of letrozole, doctors are usually giving 4 to 5 cycles. After that, they are reassessing patients. So 3 to 4 cycle with letrozole is okay.
One more point to be noticed here is that, look at the mode of action of clomiphene citrate. Clomiphene citrate only suppresses, is only an antagonist for the estrogen receptors. And that again, the half-life is 2 weeks. The effect takes about 6 to 8 weeks to drain off. So therefore, once that with FSH or the HMG dose, a higher dosage is required, because number one, it blocks the estrogen receptors for a prolonged period of time. It increases the estrogen quantity. Now, as a result of this, what happens is that the amount of FSH that has to be given exogenously has to be more. So that again is a big comparison where the long-term usage comes into the question mark for clomiphene citrate.
Okay, thanks. Can it be used in fibroids? No, it has no role in uterine fibroids. Adverse effects of high levels of estrogen. So estrogen will probably have a lot of effects in female body. Right now we are just discussing female body. So it will lead to a lot of weight gain maybe. It will lead to the headaches, hypoglycemia, the changes in the breast tendon. It will lead to the tender breast. It will also give, it might give amenorrhea, or it might give you irregular menstrual cycles. Then it might lead to the water retention, bloating, all those stuff. It will definitely have negative effects on bones as well. So anything we want to add?
The general feeling of well-being will be reduced with prolonged
mood swings. Yeah. Okay. Are AIs hormones? No. Aromatase inhibitors are not hormones. Aromatase inhibitors are drugs. Aromatase inhibitors are drugs which were actually originally developed for the treatment of breast cancer in women. Now we are using, and letrozole has proved its role in also in the ovulation induction. So just keep it in mind that aromatase is an enzyme. Aromatase inhibitors are drugs. They are drugs. Okay.
There is one more question we have just now received. I found it little surprising, but still, let us answer the question. Even if one person is having this confusion, is not advisable. One of our colleagues is asking whether letrozole is an indirect competitor of our product Yamini.
And we would like to understand from where this question has come, because Yamini is completely a different indication. Yamini, the two primary indications for Yamini, number one would be for regularizing the menstrual cycles, and the second would be as a contraceptive. So, I mean, I think the indications are completely different. Although COCs are also used in infertility, but the usage is totally different. The usage of COC like Yamini in infertility is to regularize the cycles before the doctor goes into an infertility cycle. But here it is once the doctor enters into the infertility cycle to increase the chances of ovulation in anovulatory infertilities, letrozole is indicated. So the indications are not same; they are not overlapping. The indications are totally different.
Okay. So I think this concludes almost all of our questions related to medical. So I really thank very much to Dr. Mane and Rakesh for taking us through the medical aspects related to brand Letrozole. I'm sure by now each and every medical query, none of the person would be having any such query further, because all the questions have been taken up over here in the moderation and then has been responded very well. But there are certain marketing queries. I'll come on to those marketing queries with my closing remarks only. I would like to summarize this entire presentation and would like to focus upon certain things. Now, firstly, as I earlier also mentioned and our other colleagues also have shown you, that Letrozole is coming or is being relaunched because Letrozole was banned in India in 2011. So there has been a gap of around 6 years. So it is being launched after 6 years, and my colleague Saurav has shown you that Letrozole's ban was clomiphene citrate's gain. So whatever Letrozole banned or whatever Letrozole lost, clomiphene citrate has gained it, because here I would like to whether they can see our slides as well. If we can show that particular slide where I would like to go back to that bar diagram of the market. So I would re-emphasize this particular point.
Like currently we are
just a minute. Yes.
We are on the full screen.
We are on the full screen?
We are on the full screen.
Okay. So no problem. So if I would just recall, now Letrozole used to be, or Letrozole market used to be 56 crore, which after the ban gone down almost somewhere around 11 crore or 10 crore. Now you must be thinking after the ban why it was still 10 crore, because it was promoted in breast cancers. As my colleague has earlier also mentioned, it is promoted in breast cancer cases as well. So there were still some amount of sale of Letrozole was there. But after the ban is removed, now again you see the good number of competitors has come in and they started aggressively promoting Letrozole to the doctors in ovulation induction. And what you are seeing earlier, what used to be, there used to be somewhere around 22,000 prescribers. I'm not talking about the molecule over here. 22,000 prescribers were there who were majorly, or rather 22, it has reached to 26,000 who were prescribing either clomiphene citrate or Letrozole as a first line therapy. So what I am saying, right now there is only 3,500 doctors who are currently prescribing Letrozole. So the doctors who were earlier having faith on Letrozole or Letrozole, they would again bounce back. So now this ball are already started rolling. There are good number of competitors who started making their doctors aware. Doctor, now ban has been lifted. Kindly start prescribing Letrozole. So that's why we have launched now. We also need to be very aggressive in taking our brand Letrozole to our doctors and inform them that the ban has been lifted. So there is no reason why you should not be prescribing Letrozole. So only 3,500 doctors right now who is prescribing Letrozole, it would reach up to 17,000 or 20,000 doctors. So now the question is, who is taking their Letrozole brand to these many doctors? Faster would be the company, greater would be the benefits. So the thing is that we need to be very aggressive in taking it to the good number of our doctors, and that's why my colleague Saurabh has been saying kindly initially at the launch time expose letrozole to all gynecologists, because all need to be aware that ban has been lifted and letrozole is available for or to be prescribed in induction of ovulation, right? So another thing I would like to say that you would have seen whatever is the volume right now, there is 35 crore is the market right now. In that 55% of the market share is with one company, that is Sun, and with two brands. So the point is that if beyond clomiphene citrate remains our first choice, because right now there is majority of doctors are prescribing only clomiphene citrate. So as per strategy, we need to go to maximum number of doctors, and whosoever is a clomiphene citrate prescriber, we need to aggressively tell them that doctor, there is no reason you should now rely upon clomiphene citrate because letrozole is now approved. Now, what I am saying, there are still the doctors who are prescribing letrozole as a second choice. If you would like to target the doctors who are prescribing letrozole, let us target one brand, that is Letrose. Now, there is another brand, Letovol, which is also there from Sun, but they are majorly promoting as an onco indication for breast cancer, right? So, target one company of letrozole, that is Sun, in terms of our marketing, if we have to target the doctors who is prescribing letrozole. So these are few of the things that I wanted to tell, and even the largest brand, which is Letrose, what we are talking about, it is already more than 10-11 crore brand, Saurabh, right?
10 crore.
So it is already 10 crore brand, and currently the doctors, the number of prescribers they have is 1,800. Now 1,800 as per our field force, if we look at, it would be somewhere around 5 per person. So not enough number of doctors has already started prescribing Letrose as a brand, and that's why I'm saying don't go blindly only after Letrose. Firstly, target clomiphene citrate, and then if there are certain doctors who are prescribing Letrose as a brand, we can target them as well.
Here I would like to add one thing, that so as we have already brand with us letrozole, we must be having some prescribers in the past. No? So we have to go towards first them. So I understand half of the field force is new, but yes, your leadership is not new. They must be knowing that yes, there are some of the prescribers. These are the doctors who were prescribing in the past. Now take the help of your superiors, your RSM, your ASM, and then go for
all those doctors who were earlier prescribing your letrozole. They need to be again reached back, and you need to inform them, the doctor, your letrozole is now once again available to be prescribed under ovulation induction, right? Now, one important aspect I need to tell you, because many of you are new, when you go back to your doctor, they would say, have you changed the spelling of your brand name, right? Yes, we did. Earlier, the brand name was available with letrozole, L-U-T-R-O. Now the brand name is L-U-T-R-A. So it is just for your information, nothing big. It's just for some regulatory requirement, we did change little bit. Okay, so the brand name is letrozole now, which earlier used to be letrozole, right? So this is the important thing I wanted to keep you informed. Now there is another thing.
There are two questions are there.
Three.
Is it related to marketing?
No.
No.
Okay, so let me first take all marketing related questions. Yeah. So samples, as my colleague said, that there are certain, just for the launch sake, we are converting sales stock into samples, because as you know, the duration of course that is very small. It's only 5-day therapy in a cycle. Okay, so in a cycle, when we say, that means for the entire month. In the entire month, only 5 tablets need to be given. So there is no point you giving samples of 2 tablets and then person is trying to purchase 3 units from the market, because no chemist would be giving 3 tablets out of a 5-strip tablet. So that's why we took a call. We have done conversion from sales to sample. So when you are giving sample, it is one patient's full course for one cycle. And that's why we are giving you 30 units. So each doctor 3 units. That means samples enough for 3 patients for one cycle. And that too for 10 doctors. This is important to understand. And now this is one time we are giving, so that in the first visit itself, there would be strong brand hammering remains. Because if you also understand, one sample course means one cycle lost. We are not going to get the sale from that particular patient whom you have given the sample. Okay, so anyhow, for brand registration purpose, we are giving these initial samples. Use them judiciously as directed. It is for the brand recall. Then we are talking about, definitely, like my colleague has already mentioned, the launch visit. We have discussed about 9th November, keeping 9th November as the All India launch date. Why? Because you guys have just now built Lutrozole. The stock would be reaching to your headquarters. I'm sure you require almost a week's time to make the product available at your respective chemist counters, because you already have the survey with you. You must have found out the major letrozole prescribers, the major clomiphene citrate prescribers, and if you have not done so, kindly do it in the next couple of days, so that you can make your product available to all these counters, because we have seen as a division we have not been good to maintain the availability of our new products. So that's why we are giving you this time to ensure that the availability is ensured before you launch this product to the doctor. So on the first day itself, you would be able to do the visual aid detailing, you would be able to give the samples, you would be able to give the product monograph, you would be able to give the availability card. These 4 things you will be doing in the very first visit itself, which would have a significant impact in the doctor's chamber for this brand. Now, there is one more thing I have noticed in some of the questions people have asked about the price, that we should be economical, that we should be price friendly. And one of our colleagues has mentioned the name of Cipla, that it is available with 60 rupee per strip to the patient. Now, let me tell you, there are a couple of things we need to understand. Let us start or stop comparing ourselves with the companies whose promotional strategy has been always based on the pricing. So we firstly do not belong to that category of companies. Second thing, now when it comes on to price friendly, okay, or patient friendly pricing, it is already like that. Let me tell you one also important point which has not been discussed up till now. Letrozole is under NLEM. I'm sure you all are aware about NLEM, National List of Essential Medicine. So government does that. So government has already identified the patient friendly pricing for this. Okay. So no other company would be able to charge more than that. What we exactly are doing, we are giving exactly the price that government has decided. Now there are companies whose brands were available for quite some time before the molecule came into NLEM. That's why they could not increase the price to match the NLEM. Since we are launching now, we are matching NLEM price, and it is very economical. If I would ask you what is 190 rupees for a month, you compare it with any of the product that is there in your basket, you find it much economical than that, isn't it? I think that it makes sense, because 190 rupees for the entire month course is actually nothing. It is so very economical, right? So let us go ahead with this pricing with a bang in the doctor's chamber. Do not discuss pricing with your own initiative, because it is of no value. A patient who is going to the doctor for the treatment of infertility, actually the price does not matter, and more so when there is hardly any price. Okay.
Another thing for pricing, I would like to add one point. For pricing, please understand this letrozole treatment or cost or MRP which is set over there, this is for 1 month. It is not like for say 3 injection, or that is for weeks they have to take around 30 injection or 40 injection. It is not like that.
So 190 rupees,
190 rupees for entire month. So patient will not bother about pricing, and doctor will also know, you will not get query from doctors also regarding the pricing.
Right. So this is one thing. Now apart from this, in fact, is there another query, another marketing query which is remaining that need to be addressed? No. So now one more thing. So since we are now this October end, So what Saurav has shown you is the 3-visit chromatogram.
Yes.
That means the November first visit, which is starting from 9th November. Okay, from 9th November to 30th November, you will complete 2 visits, right? And then in the first half of December, the 3rd visit. So these are the 3 visits inputs or promotional plan Saurav has shown. In December, we again would be meeting in the cycle meeting, right? And then we would present you the remaining half of the December, what you would get, and then what you would get in Jan, Feb, March. So that is how the promotional plan is created, and that's why Saurabh has shown you only 3 visits input, because in December we are anyhow going to meet. We would be having a kind of a refresher over there. We would try to get the experience from you. We would try to get the feedback from you at that point of time. So with this, we should launch it with a significant impact at the marketplace, and we would like to keep on listening the success story through all of you, through mails, through WhatsApp, whatever way. So either through Saurabh or through your leaders, and ultimately you can write mail to anyone over here, and then we would be compiling it. Okay, so with this, now I think there are a couple of more medical queries. I'll hand over these for Abhay and Rakesh. So which are these queries?
So there is query which says that letrozole, can it be used in patients suffering from thyroid and diabetes? So my answer to this question is, if there are major thyroid issues or there are major hormonal issues, and if the cause is somewhere in the pituitary, or if the cause is somewhere in the hypothalamus, suppose there is a pituitary tumor, then that is a very different issue, and that has to be sorted out first. That has to be treated first. But if it is a thyroid or a diabetes problems which we see in general population, then letrozole is not as such contraindicated, right? It can be used.
Okay. Okay. Another query.
There is one more query which is interesting. Is it used for gynecomastia? So as such, no. There can be offline use for gynecomastia, I'm sure, to bring down the estrogen levels.
It is not approved.
But it is not approved, it is not indicated, and I really don't want you to go into something really different. Just focus on ovulation
absolutely. What we have discussed about the indication, let us be focused on those indications.
Exactly.
Beyond that, if any indication doctors are asking you, you can always come back to us. Or up till now, whatever information is given to you, there are certain indications where it is not approved. We can straight away tell it to the doctor, or where you do not have a clarity, you can always write back to us so that we can respond in time.
So ovulation indication, as such, one indication is a huge indication for you. So no need to worry about all other indications.
Okay, so this concludes.
There is one more query, like, does Richova SR and letrozole play the same role? Not exactly. Letrozole, as we saw, that it basically see, the focus of letrozole is what? The focus of letrozole is that it results in more production of FSH by not inhibiting. Estrogen inhibits the pituitary gland, and that reduces the production of FSH. By not inhibiting the pituitary, we are resulting in more FSH, which results in the growth of the follicle. Now, Richova, if you look at the composition of Richova DHEA is basically a precursor of androgens, and that is more towards the initial growth of the follicle. It's like towards the when the primordial follicle has just started growing into the primary follicle. That stage, androgens are more required. So we are not exactly talking of the same thing. Where one case we are talking of the primary follicle is not growing into the secondary follicle and matured Graafian follicle because of lack of FSH. On the second side, we are talking of antral follicles, which are just, you can call it like, the very initial primordial follicles which are growing into primary follicle. So therefore, not exactly the same thing. The focus is slightly different.
In case of Richova SR, the FSH is there, but though FSH is there, these follicles which are there, they are not responding to the hormone which is there.
The antral follicles are not responding.
So these follicles are not responding. FSH is there in that case, in case of Richova, where your ovarian reserve is low, and that particular low reserve is not responding to the particular hormone which is present, that is FSH. In case of Lutrazole, we are promoting or we are stimulating to produce more and more FSH so that it will reach there and stimulate the antral follicle to grow further. This is the basic difference between two products, Rich OSR and your Lutrazole.
The positioning is a little different, although primarily when you look at it, it comes out to be the same indication as infertility and and there is a role of androgens and estrogens to play. But there is a slight differentiation between the use of the two products.
Okay. So this concludes all the queries. Now I request one more thing with all of you. The detailing guidelines of the gimmick visual aid has already been shared with all of you. So wherever you are, kindly practice for the next half an hour or 1 hour with this detailing story, how exactly you are going to detail in the doctor's chamber.
So has been reached in RSM office.
Yeah, so where the visual aid has already been reached. In fact, there are quite a good number of our colleagues who are sitting with the RSMs in the regional office. So with the visual aid, as it must have reached at certain locations, and with the detailing story, I would request our RSM to take it up with the area manager along with the representative to practice it over there, and then they should leave for the evening working. So with this, I would be concluding this Lutrazole launch session, and I would thank very much once again Dr. Abhimane, Mr. Rakesh Singhal, again Saurabh in my team, and also one very important colleague of ours is Sonika, who has spared a significant time coordinating with all of you and rectifying all the technical snacks that you all had. So I'm sure since this was the first experience with webinar, I'm sure that you must have liked this experience with webinar, because at one go itself we are connecting with all of you. Please keep sharing your feedback, and I would simply request that even through your area manager or through your RSM, kindly share your feedback of your experience with webinar launch. This would give us the understanding that in future, in what all platforms we should be we should explore this kind of a platform little more for not only product launches, but maybe for other kind of meetings as well. So I request all the RSMs to share their feedback also along with certain technical problems that they faced, and whether these technical problems were significant enough, how we can avoid, and all those things that we'll definitely look into. So do share your feedback. With this, I thank you once again for joining, and have a successful Lutrazole launch in your respective territories and the markets. Thank you very much.
Thank you.
Thank you.
Thank you.